Well, good evening, everyone. It's Gene Santucci. I'm coming to you from lovely California. I'm about 20 minutes or maybe 15 minutes from Stanford University, about 40 minutes south of San Francisco. It's a gorgeous California day. It's about 5:30 out here and the sun is shining and about 78 degrees. So I hope it's great where you folks are. Background here when I start, I'm a general dentist and been playing around with TMD and a lot of sleep recently and parafunctional habits alike. So this presentation is at a level for us general dentists and listening to hygienists who are here and front desk people. And essentially what I'm trying to do is bring some information where we can help our patients and from an emergency and maybe understand that there's certain things we can do as a general dentist and other things that perhaps we should refer. And coming closely in with this, there'll be some things on sleep, and there'll also be quite an in-depth conversation on various types of bruxism and how they affect our patient, and perhaps what is the etiology of these problems. If you look at the screen, you can see all the possible things that involved in TMD. All these forces from sleep to trauma to bruxism. And occlusion here is the big one, and we'll talk about that later. Occlusion now may not be as big as it was, 10 or 15 years ago, and we'll get into some of the background on that. Some of the things we're going to cover. I'm going to start off by reviewing some of the basic components of the joint and the muscles, how these interact, and starting with the basis, then we kind of get some idea of what happens when they go off the rails. We'll consider some of the etiology of some of these disorders and parafunctional habits. Are all parafunctional habits alike? Are all bruxisms alike? And then what's our role, your and my role as a general dentist, to help our patients with this? And many times it's an emergency, and the emergency is like Friday at 3 o'clock. And one of our patients called, they're in severe muscle pain on their face, they're anxious, their daughter's getting married tomorrow, they need something. Can we help them as a general dentist? And we'll get into that also. I'd like to start off with a little bit what I call the red flags of the TMD. Some of the things we'll talk about are huge red flags, some are very smaller flags. I always look at this as kind of a Sherlockian adventure. Sherlock Holmes, there's a murder scene and the police are in there and they're stepping all over stuff and he kind of picks up one little hair and 2 weeks later he knows who the killer was. When I interview a patient or deal with a patient, I'm looking, is there something that we've missed? Is something that people have missed in the past? And, is this something Sherlock Holmes will find and cure the situation? So I look at it as that type of an adventure. We have to understand that temporomandibular disorders is not a part of the dental CPT codes. It's actually a mental, it's under the musculoskeletal disorders, and it's in there with myasthenia gravis, carpal tunnel syndrome. And I mention that because if you're treating other than with a night guard, let's say you're doing Botox or something like that, you have to know the medical CPT codes. If you try to build these through dental, you're not going to get paid for it. So I'm sure those of you who have taken those classes, I'm sure they've given you some of those codes that you can use, but just to make sure here that it's not, quote, a dental entity, it is under the musculoskeletal disorders. So patients will come in and they'll say, "Oh, doctor, do I have TMJ?" And I joke around and I'll say, "Well, I hope you have two, and one on each side." And we know that it's not just the joint. It is this entire gnathostomatic system with the muscles and the nerves and everything else working together to make it work, or also to get it off the rails and us to try to get it back on the rails again. So it has this more worldwide part to it. It's not just the joint itself. If you had to consider the signs of TMD, and because signs are something we could measure, we can hear, we can see, etc. About, I don't know, 75% of us in the audience would have some sign, whether it's clicking joints, crepitant joints, deviation on mandibular opening, looking at something intraorally where we see a lot of wear. So this is something we can see, we can measure. That would be, the majority of the people in our audience tonight. On the other hand, the symptoms are difficult. Symptoms is something we cannot measure or see. Symptoms, what has to come from the patient, and normally there is this medical pain cycle where we go from the pain either to trauma, direct or indirect. We get a constricted blood supply. It's almost like if you're overworking a muscle and you build up lactic acid, uh, and then you have to get that out and you have to get the good things in. It localizes in a certain area. We start getting inflammatory changes in the muscle, and then eventually we get muscle soreness and eventually pain. So this would be the symptoms that we would look for in our patients. Then who actually needs treatment? Only about, I don't know, 5 or 6% of our patients actually seek treatment. And 4 to 1, mostly women. Why? Well, they're the caretakers. With the kids and stuff, something's hurting. They're the first ones to think of going to the physician. Sorry, guys, we're kind of dumb. I always think of that Monty Python skit where the two knights are crossing the bridge and they won't let each other go, so they start fighting, and the one cuts the other guy's arm off, and he says, "Oh, merely a flesh wound." We seem to be, we have to be in total trouble before we go to physicians. But something else, if you look at the bottom here, in Australia, there was a study done, and they found in baboons that in female baboons, there is an estrogen receptor site. So the thought is that there is a hormonal implication of perhaps why some of the joints are under more dysfunction than in a male. And I notice it in my patients. I'll have them in a typical night guard for some very mild muscular reasons. And I'll get this call and they'll come in and, oh my God, Dr. Santucci, all this thing was stable. Now I'm hurting more, this and that. And I'll say something that usually shocks them. And I'll ask them, I say, are you pregnant? And they'll look at me like, nobody knows. How do you know? And he's got to laugh. So we'll stop and think about it. What happens when you're pregnant? The ligaments, in the pelvic areas have to relax and stretch, or else none of us would be here, really. Well, it's not just those ligaments, but the ligaments throughout your whole body also become more lax. The ligaments in this joint, there are 3 or 4 of them that hold everything in place, they become more lax. And so you get more flexibility in the joint, more movement, brings on some discomfort. Usually tell them, hey, a couple of weeks afterwards you deliver, maybe 4 or 5 weeks, it should come back to normal again. So again, there may be this is done on baboons, right? So we haven't done it on people as of yet, but there could be an insight on that. I turn this up because if you look at this, and I'll ask you, do you think, how old do you think this patient is? Well, it's kind of hard to say. And, there's full molars, there's all eruptions, it's not 18. But actually, when this was taken, she was a 24-year-old hygienist and toured the country getting treatment done and knows enough about dentistry to have people do treatment on many times teeth that were perhaps both radiographically and clinically, there was nothing that said this tooth needs to have treatment done. Brings the people in, they start doing the treatment, and many times they'll go back and they'll do the endo, and then they have to do a retrofill, on and on and on. Why do I bring this up? If we see the patients, whether it's a regular patient or a new patient, and they'll point to an area of discomfort, and yet we'll probe clinically, a vitality test, radiographs, percussion, anything we can do, we do not get what we would consider a positive response or, hey, I think this is necrotic or whatever, let's open it up, let's do X, Y, Z. So there is this emotional component to pain, and some people will fool us. And I guess what I tell my students, along with other people on when I'm touring around, is that if you're not 100% sure, don't pick up your handpiece. Don't pick up your handpiece. It's okay to say, Mrs. Jones, there's nothing I see clinically or radiographically that suggests that I start doing treatment on this tooth. There are specialists I could refer you to, but personally, I don't feel good in doing this. So it's okay that we say no to patients if we don't feel comfortable that it's within our realm of treatment. Okay? Let's look at the muscles. Now, there are about 20 muscles in the face, and for the most part, we're just concerned about, excuse me, temporalis, the three bellies of the temporalis, sternocleidomastoid, and I'll show you that. Floor of the mouth, temporalis tendon, and I'll show you where that is. And two of the major ones for moving this jaw around is the superior and inferior lateral pterygoids. And so in our exam, these should be addressed, and you can do it very quickly. It doesn't have to take time to get this done. Now, I don't know if you're aware of Janet Travell. She was the physician that took care of President Kennedy. And as you recall, President Kennedy in the Korean War was on PT, was it PT 109, and his back was pretty well hurt. And he was on heavy medications, heavy drugs for a long period of time. Janet Travell started this concept of myofascial pain and dysfunction, trigger point therapy, and referred pain. Referred pain means the patient may be pointing to one area, but the nidus or the etiology of that may be somewhere else. And the skilled people can palpate and find out where that area is, dry needle it, or put in some xylocaine, and the pain goes away. And I mention this because in dentistry, we see some of this. And a lot of times when we see pain that we don't know where it's coming from, just kind of think of the referred pain context. So if you're looking up here on the upper side in section A, patient complained of pain in the maxillary left quadrant, and yet we evaluate and we don't see anything. People who are skilled at this will palpate the masseter, and they may hit these trigger zones right here, which will then increase or trigger the pain. Again, you can see the same thing for the lower teeth, here for the crest going over the eye. And the one that's really critical is D. You can palpate the masseter, and the deep belly is very close to the temporomandibular joint itself, and many times the patient feels that the pain is coming out of the joint itself. Of course, you would have an audiology doctor, EMT, check that to make sure there is nothing wrong with the ear, but also think that it could be referred pain in this area from the masseter muscle. Again, you can see the thing with the temporalis and the areas that it would also refer to. Now, I don't want you to, memorize this or write it down or anything, but just the thought process that if your exam is coming up with nothing positive showing, it may be this referred pain situation. And many times it goes to the teeth, and that's, of course, where we live every day. So when I do an exam, I'll sit behind the patient, not off to the side. And in doing so, I'm watching the patient as they open and close. I'm looking at the mandibular gait. Is it very fluid, or is it kind of staccato-like? Does it deviate to one side or the other? Also in this position, I can have them clench, palpate the masseters, and I can also percuss and also have my hands over the joint to see if I can pick up any joint sounds. So this one position, very quickly, pick up quite a few different items. Okay, go on to the next one. Also, we rarely go up and palpate the sternocleidomastoid, and I'll show you why that's critical in a moment. So normally, turn the patient over to one side, support the head. Now, there are two bodies to this. One's the clavicular, one is the sternal head. And many times in palpating and gently massaging this, there will be a referred pain above the eye and into the cheek area, thinking that it's, essentially something dental to begin with, but actually it's referred from the sternocleidomastoid muscle. And you can see here the referral pathways. You can see frontal headaches under B, ear pain, and again, it should be checked by ENT or an audiologist to make sure that there's nothing going on within the ear itself and around the eye itself and a little bit behind the head here. So again, things you would not normally do, but if you're not getting any positive answers in your workup as to why things are happening, this referred pain concept may be something that's worthwhile. Also, palpate bimanually inside. If there's area of discomfort, does this elicit any discomfort as you're going around with your bimanual palpation? And also, you can come back here after the cheek, and you can come behind the second molar, come up the ascending ramus, and many times you will elicit some discomfort. Why is that important? Well, all of the temporalis muscles come underneath the zygoma, and then that comes down with a tendon right onto the head of the condyle. Many times you won't get pain by palpating the temporalis muscle, but you will get pain by going up behind the second molar, up the ascending ramus, touching the head of the condyle, touching the coronary process, and you will eliminate some pain. Again, just the thought, if you're running out of ideas, sometimes that does work. And then these are just digastric muscles, and most of this is just the lower anterior teeth. Okay, so in general, just another scope of perhaps what you could be looking for that maybe you have not looked at before. And sometimes it may give us some ideas. Now, also range of motion studies, and we want to get, as far open as the patient can and how much they move from side to side. Now, if they have maybe a 3 millimeter overbite, well, and they open 40, it's actually 43. It's the 40 we measured edge to edge plus the 3 that they're overlapping. And if they present with an anterior open bite and the open 40, it's actually 37 because this is anterior open bite, so you subtract 3 millimeters. So again, also look at not only the vertical opening, but we want to see, is it equal from side to side? And is it pretty straight in protrusion where the mandible doesn't deviate from one side to the other? Now you can use a Bowley gauge like this. I don't particularly like this. I don't like to see this kind of piece of metal coming towards the patient. And so I like to use what's called a TheraBite. And this is either something you can autoclave or it comes in sheets where you can just use one and dispose it. It's clean, it's easy, it's atraumatic to the patient. And again, you can get your maximum opening plus taking in either an open bite or an overbite to begin with. Then you can also use it you could go side to side, pick up the lateral excursions. Do we have equal movement on both sides, left and right? And when they come into protrusion, do the midlines stay right on line as they're supposed to? Another thing to consider is sometimes we get a lot of back neck pain radiating to the face. And this is just a diagram showing that normally as we're standing upright and we have normal posture, our head weighs about 12 pounds. Just coming forward about 2 inches, that head is now 32 pounds of weight. And 3 inches forward, we're up to about 42 pounds. Well, sometimes you can tell older dentist a mile away because they've got that forward head posture because of sitting over the chair like that for years. Now, thank God our students today have the ergonomic loops where they're looking straight forward as they're working, and also that greatly helps their posture, their head position, and they don't start getting into that forward creeping head position side to side. Now, having worn the other loops for the better part of 30 years, I tried the ergonomic loops and I don't know where I am. So I'm stuck with them, I guess, till the day I stop doing dentistry. But again, just posture also has a condition. And I'll show you another one that we don't think of. Patients will come in and I'll ask them, well, muscles of mastication, the masseter is hurting, anterior temporalis. I said, are you kind of clenching or grinding your teeth? Oh, no, I don't do this. And then I'll ask, what do you do? Well, I'm at a computer, most of the day. I said, well, look at this. You're at a computer. You're sitting pretty much upright. Then as the day goes on, you get tired and your head kind of comes forward into this position. Well, if you go forward in this position, your jaw slides forward. And in many of us, we start traumatically banging the linguals of the maxillary teeth. Well, that doesn't feel good. So what do? We bring the jaw back and then we clench it to keep it there. Well, you're clenching, so now you've got the masseter and anterior temporalis becoming hypertrophic, and you not realizing it that your posture may be bringing on these traumatic muscular experiences. So again, asking the patient what they do for a living, have them even stand up and see what their head posture is like, because a lot of this could be brought on by posture, and we're not aware, they're not aware of it, and sometimes we bring it to their attention. These last couple of things have to do a little bit more with sleep, but we could go very quickly and look at the Brodsky classification of tonsils. If they're grade 4 here and they're kissing tonsils, they're not breathing well, especially when they lay back. And then they have to go into other things to wake themselves up to breathe. Another criteria is a scalloped tongue. And we're thinking about parafunctional activity, and you look at the scalloped tongue, and we say, oh my God, Mrs. Jones, you have a scalloped tongue. And poor Mrs. Jones, her eyes get bigger, 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 right? And we said, no, no, it's nothing bad. It's not cancer. It's just telling me that you're doing something by causing these grooves in your tongue. These are some of the possibilities of things that cause a scalloped tongue. And the most noticeable would be sleep apnea, and I'll get into that, and parafunctional activity. And at least you have some rationale of why the patient is doing what they're doing. You can give them an answer. Malapati index is another one. And you look back in the back of the throat, you have the patient stick their tongue out, and the classification is 1 to 4. And if you're a 3 or a 4, when you lie back, you're not breathing very well, and it may bring on some other sleep problems, and then clenching and grinding, which I will show you. Lingual frenum, we don't think of this too much, but when you're developing in the developmental stage, the buccinator muscles are pushing in on the maxilla, and then every time you swallow, your tongue goes up there and neutralizes that effect. If you have a restricted lingual frenum, when you swallow, it does not go to the roof of the mouth. And instead of a nice dome roof, you get a very, very vertical roof like this, and there isn't enough room for the tongue, and you become try to do a mouth breathing, and you go to all types of developmental things. In Brazil, at birth, they check the child, and if it's restricted, they snip this at birth. And that's how severe, how much they think about having this restricted frenum and what it does to maxillary development. Okay, so TMJ evaluation. We'll palpate the joint, of course, and it's interesting to figure out or put down what the sounds are. Are they clicks? Are they pops? Is it crepitant? When does it happen? When does it happen at the opening, at the closing cycle, early or intermediate? And then we can put that in our chart. I'm going to show this very short video, which is a very brilliant review of what happens in this joint as a review, because over a period of time, I know we forget. But before I do that, because I forgot, you're not a doctor unless you have a stethoscope around your neck. And, this is always impressive to the patient. And we can use the stethoscope to pick up some sounds, even though we cannot feel them as we're palpating side to side. And you can wear this around the office and say, I'm listening to joints. So, people laugh. So anyway, you can use your stethoscope. Okay. So here's that
The
little
temporomandibular
video.
joint,
It's short.
TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
So the reason I like this video is I thought way back that the clicking was as you open, the disc pops off the top of the head of the condyle. Just the contrary. The disc is forward before you open, and the click that you hear is it jumping back onto the head of the condyle. I'm going to do a little demo as to how you get these clicks classified. So for example, if you're opening a little bit, you hear a click, you open all the way, and then you come back and you hear a click. So that is a early opening click and a late closing click. The other would be open, 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 click, and then as you go to close, click. That would be a late opening and an early closing. And it's good to put that in your chart, so in case anything changes, you have that when were the clicks occurring, along with is it a click, is it a pop, or does it have a crepitant nature to it? Okay? Now, I hope that helped as a little bit of a review. The other most important thing is that if your patient is in discomfort, it's important to try to figure out, is this pain coming, is it intracapsular within the condyle and the disc itself, or in the capsule itself, or is it extracapsular? Is the pain coming from the muscles of mastication? And how are we as general dentists supposed to figure this out? Well, this is what's called an NTI, and it's essentially anything you put in the front there will be what we call a discluder. If the patient calls, as I said, as an emergency, and we have no idea and we have no models and stuff, you can't use this because this is made by a laboratory, and I'll show you what you can use in an emergency. But to back up as a diagnostic tool, if you use the discluder, you put it in the patient's mouth, and you have them sit there in your office for a period of time, if we get a decrease in the pain, that's a good indication that the etiology is extracapsular. It's muscle. It's outside of the capsule. If by using this we get an increase in pain, usually it means the discomfort is within the capsule itself. Why is that important? Well, muscle we can try to help with our massages and our heat and cold and using a night guard. Intracapsular pain is something that is done by the specialist and referred to a facial pain specialist to help with that. So this is a diagnostic tool. I don't like using this, especially for long periods of time. I'm always afraid people are going to swallow this thing. I'm concerned about intrusion of 8 and 9. I'm concerned about extrusion of the back teeth, even though it's supposed to be something very short-lived and short-term, and they're not going to wear it to bed. And this shows you in all excursions, everything is on those two anterior teeth and the ramp that it creates. Another item is called aqua splint. And this is, they come in small, medium, and large. And there are two bags, each filled with saline on either side. And this goes in above the lip, around the back teeth, and you put it over the molars. And the patient can kind of bite on these two little bags of saline. And in some people, this works very, very well. The one I like the best is Quick Splint, and this is by one of our sponsors here, Kettenbach. And essentially, uh, it comes in this little container, and this is the Quick Splint. And I'm going to go to demo mode next. Would you please? And so all you do then is fill this little container. First of all, you can try it in the patient's mouth. It's kind of universal. They all seem to fit pretty well. In a smaller mouth, it goes back a little bit further. And then you could line this with either bite registration material or I like to use a little bit of putty. So we're mixing up the putty here. Get it mixed real well. Pack it into the splint. Make it nice and even, a little bit nicer than I did right now. And then put it in the patient's mouth. Have it run the lip over it so they contour the front. And then you can put your tongue up on the back. And so like like the cooking shows, I have one already made, so we don't waste time waiting for things in the oven. And it fits pretty well. I can move in all directions. And on mine, it's really smooth in the front because I brought my lip over it. The back of this I've extended just a little bit more, and it makes the thing very, very stable. If that's a problem, you can cut this back a little bit more for patient comfort. But this has saved me a lot of times on those Friday afternoons. It's made very quickly. You don't need models. Even your hygienist can do it under your direction. And I highly, highly recommend this. And again, the patient has to understand that all of these items, and even this quick splint, it is short term. It's a couple of days. Are you feeling better? Is the pain going away? If you're having problems, stop wearing it that we may have misdiagnosed, and it may be something intracapsular other than extracapsular. Okay? Quick splint by Kettenbach. We thank them for supporting us tonight. And then, as I said, if these items do not work, then I think you should refer to a specialist. Now let's go shake a little bit into bruxism. Are all bruxisms alike? John Rouse came out with this study in 2010, and he said that in a lot of his TMD patients, he found this triad, and with him it was GERD, sleep bruxism, sleep apnea, and either he had one or two of these. Over the years, I've added TMD problems, I've added erosive tooth wear, I've added saliva. Not room in this in our talk today, but all of these things come together, forming this triad or forming this group of problems that come with TMD and bruxism. So when you're looking at something that is worn down as much as this, is that simply from bruxism? A study was done, I don't have those slides with me, that over 30 years, they estimated and they measured that natural wear on teeth should be about a millimeter to 2. If there is acid in the system, whether intrinsic or extrinsic, coming up from your tummy or something that you're ingesting with a lot of sports drinks, etc., that wear is about 27 times greater. And wear like this, you see, has to come from other than bruxing because you don't brux down here. So when you see this, a lot of this excessive stuff is wear, and it's usually a combination of bruxing, parafunctional activity, plus acid. The next is sleep, bruxing in your sleep, is it the same as bruxing when you're awake? And should you use a night guard in either or both conditions? Oh, sleep bruxism versus awake. Sleep disorder is set up by your brain. You're asleep, a series of things occur, and I'll mention a little bit in a while, that forces your mouth to stop clenching and grinding, and you take a breath. So you have no control over this. This happens while you're asleep. Diurnal or day bruxism are simply habits that you have developed, whether it's biting your nails, biting a pencil, grinding on like this, at the computer, something that you do have control over, as opposed to nocturnal, which you do not have any. A lot of this has gone into by Gilles Levine. He's a great friend of mine up from Canada. And this is a textbook that I would highly, highly recommend. When you ask patients about, hey, do you clench or grind your teeth? They're terrible reporters. Those that say they do actually don't when you test them with EMG, and those that say they don't, they actually do when you do EMG studies. So just asking them is difficult. And other than EMG studies, you're not going to do this on your patients. But sometimes the spouse helps. Yes, you do clench. Yes, you do this. Yes, you do grind. Yes, you do hold your breath. And most of us, it's us guys at the end of that. So here's what happens when you're asleep. So up on the top line here, we have the masseter muscle, and then down here we have the patient's breathing. And as he comes to this port here, he stops breathing, and you get about 22 seconds of apnea. Now, apnea means other than there's a complete loss of 30% loss of oxygenation. Your oxygenation goes from the 90s down even like to the 70s, or 3% to 4% loss. Snoring, you're actually getting some breath coming in, some oxygenation, but it's not pure. So the difference would be you're snoring, 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 and then and then you take a big gasping breath. Okay. So during that time that our patient was apneic, those 22 seconds, here's the masseter muscle. It's happy, happy, happy. Then all of a sudden, look what happens to the masseter. And then right after that, the patient wakes up and then he starts breathing normally again. So there is this life-saving mechanism that those are people who do become apneic at night, and it all has to do with the direction of the brain. So as I said, sleep is centrally mediated, and there's a change in the heart rate because as the brain says, I'm not getting any oxygen, I don't want you to die, there's a message that it sends down to the masseter muscle to start clenching and grinding. And in the process, you wake up and you take that little breath. Okay? So it is related to your sleep cycle. This grinding and clenching is related to having a sleep problem, and this is mediated by your brain. Now, when we're looking at this, we're looking at what is this mechanism? What happens here? Your oxygen saturation drops. The brain says, I don't want you to die. It sends through the trigeminal nerve a message down to your masseter. You start clenching and grinding, and you take a big deep breath. Now remember that slide where I showed you the scalloped tongue? When you do this and the tongue comes forward, a lot of these people will also have scalloping on the tip of the tongue along with the lateral aspect of it, right? So this serious scenario is not caused by anything else except your brain saying, I don't want you to die. RMMAs, rhythmic masculatory muscle activity. This is activity that the brain forces your muscles to do to wake you up. Now think what happens here. You're losing oxygen. Your brain sends a message down to start clenching and grinding. It sends a message to your heart to start beating faster. So you're now in tachycardia. You take the breath, and now you're in fight or flight, and now everything has to settle down. And now the vagus nerve has to settle everything down. So you go through fight or flight, settle 15, 20, 30, 40 times an hour. And then people wonder why, if they're not treated for sleep problems, why they have cardiovascular disease problems. So this is a critical understanding of what happens with bruxism at night. Again, people you could ask, do you brux, yes or no? They go 50-50 either way. You can't really rely on that very much. Now, when I first saw this surprised me. This was done at Stanford by Christian Guilleminault, who was one of the fathers of sleep medicine years ago, and uh, mostly more in children. Really surprising to me, higher in children, and that as you get older, it seems to be less and less and less. Now, what happens sometimes, you look and say a person's 70 years old, excuse me, and you see a lot of worn teeth. And the tendency is to say, oh my God, you do a lot of clenching and grinding. And the patient will say, oh, no, no, I don't. Well, I see all this wear. Oh, yeah, well, I used to do this a long time ago. So my point here is that when we're looking at a patient for the first time, there is a temporal component to what we're seeing. we're seeing maybe 70 years of things going on with this patient, and we're assuming that it's happening now. So take that into consideration, ask the right questions, and hopefully we'll come up with the appropriate answers. And again, this is the awake bruxism. It's under control of, you're under it control. You can change your habits, but you have to understand or realize what those habits are. And that maybe as us as general dentists and hygienists and front desk people, if we have a little bit of a better understanding of what all these parafunctional habits are and what sets them off, hopefully we can give them information where they can stop this themselves. Along with that, remember I showed you that forward head posture being at the computer? Something similar, just by putting your computer screen up helps a lot. Now you notice me bouncing around. I hate to sit down and do this, so I need movement all the time, but it also forces me to keep my head up instead of looking down on my computer all the time. So those of us in dentistry, we're very, very susceptible to that forward head posture, and we fight that all the time, okay? And again, this is just a little bit of repetitive of what I just mentioned to you. Now, years ago, we thought that people clench and grind their teeth because of their occlusion. So, I was in heavy duty prosthetic study clubs. We used Stewart articulators, panographs. We would panograph people, putting them on these articulators, adjust everything, do the preps, get your crowns done, put the crowns back onto the model, adjust them on the articulator, back into the patient's mouth, back and forth, put these in the patient's mouth, and we had, quote, this perfect occlusion. We had patient bites down. At that time, we were doing everything in CR. All the posterior teeth, the bicuspids and the molars are touching. Nothing is touching on the anterior sextant, but about a millimeter after that, as they go into protrusive and lateral, then the anterior sextant comes into effect and disarticulates the posterior, right? The ideal muscle happy, joint happy occlusion you can get, right? Then we would make a night guard. Never thought about it at the time, but if people are doing all this parafunctional stuff because of the occlusion, and now we've come up with this perfect occlusion, why in the name of God are we doing the night guard? So that set off a bunch of studies to see what really is the etiology of a lot of these parafunctional habits. And some of the information I've just given you hopefully will kind of help you with that in mind. So why do we make occlusal appliances? Okay, well we know, and I still today, even though I think the occlusion's okay, if I do a bunch of veneers, I'll always do a night guard because if they come forward a little bit, I just don't want them popping on the anterior section, on that anterior section, and pop off my veneers. But we do appliances for many different reasons, and where is one? Now, the one that's a little bit iffy is that second one, a verified sleep bruxism. I'll show you in a moment why that may be the worst thing you can do for a patient is to make them a night guard when they have undiagnosed sleep problems. Why do you think that comes to mind? Well, if they're clenching without it and they lie back, they're still interdigitating teeth a lot, so it's kind of keeping the mandible forward a little bit more. If you put a night guard in there and they have that slickery surface and they lie back, the mandible goes straight back. So it may have been a very, very minor sleep problem, now may become a major sleep problem because we've allowed this mandible to slide back further. So we're very careful now on who we're doing night guards for, and I'll show you what I do routinely and hopefully correcting some of that. So this is the traditional Michigan night guard, occlusal dysfunction, left and right, and protrusive, and no lateral interferences. I think we notice this at all. Some people will say, well, Dr. Santucci, your night guard is, let's say, I don't know, $700, $800. Excuse me. I had three presentations this morning, so I'm a little bit hoarse, excuse me. And yours is like say $800. And hey, I was at the drugstore and for $29.95 they had night guards I can make myself. And I'll say, well, you can try that. But most of the time, they're not fit the way they should be fit, and there's no way that you could adjust them. And a lot of the success of what we do is, first of all, this is made in a laboratory just for you. And then we are able to adjust the surface to get the ideal occlusal bite that you have to try to get these muscles in the most comfortable position possible. The soft little night guards we cannot adjust. It's like trying to adjust the rubber on the tire. You cannot do it with your handpiece. And so you can try it, but I would say I find that a lot of my patients get worse because these little soft guards, these soft night guards, the patient can kind of clench into. The body thinks it's food that it wants to digest, and you bring on more muscle problems than what you're trying to save. So personally, I feel very strongly about not recommending any of the night guards that we sold into drugstores. I don't know. I never stopped to read what the disclaimer on that was, like if their symptoms even got worse. I guess I should look at it just to say, but it's so far from what I would recommend that I don't stop and look at it. The other thing is that we know about the sleep bringing on bruxism and the habits during the day. We also have to consider that a patient may not have a sleep problem, but is very, very anxious, going through a lot of stress, and they may just be stressing at night and doing a lot of parafunctional activity at night. So there is that in-between anxiety portion to it, along with the two things we mentioned, the brain in the one and the daytime habits in the other. This is an oral appliance that we make for sleep dentistry, and it's an upper and lower appliance, and it's taken into a protrusive bite. And when the patient goes to sleep, what happens, the mandible does not go back to close the space because it's locked in by the design, either with bands or rubber bands or special designs where it's brought forward or back to adjust it. So this keeps the oropharyngeal airway space open as opposed to it sliding back and being closed. This is the one I showed you before. Yeah, obstructive sleep apnea, hypoxia, a decrease in oxygenation. You get an increase in heart rate. You get rhythmic masticatory muscle activity, GERDs, and wear. So another thing you can ask your patient when you see a lot of wear is, Mrs. Jones, you have a lot of acid reflux? Oh, no, no, I take Prevacid. Well, Prevacid blocks it, but you still have acid reflux. How does that come into the picture? Well, when you're going into hypoxia, what happens is that you build up what we call a negative thoracic pressure. That pushes your diaphragm up against the base of your stomach, which then pushes up, opens the valve, and up comes the hydrochloric acid out of your mouth. And the pH on that is like 1.5. It's very, very powerful. With repeated things like this, they have precancerous lesions in the esophagus, Barrett's esophagus, on a lot of people, and they think it's from, routine acid coming up. It could be initiated by sleep and that negative thoracic pressure that's pushing on these people. These protein pump inhibitors like Prevacid and all those should be used short periods of time, yet people live on these day by day. So sometimes looking at what medications they're on may give you a little bit of an indication that acid is also in the system itself. The other problem is that saliva, we produce about a liter of saliva during the day, and the saliva, along with everything else, also neutralizes acid. Unfortunately, at night, we only produce about 10% of that. So we're laying back, we have a negative thoracic pressure, we're bringing up acid. It's in an environment where now we have 10% of the saliva we normally have to neutralize the acid. So all these things are kind of working together. So that's where a lot of the wear that we see, we can attach it to the saliva. I mean, not being there, we can attach it to the GERDs and the acid coming up. We can attach it to their sleep problem. Then there's bruxing going on. That's why there's this overall view of our poor patients, and we're trying to help them with this little piece of plastic. And unfortunately, many times it works if we do it for the right reasons and the right diagnosis. This is a typical obstructive apnea. So there's opening. If the jaw slides back, now we're constricted, and now we have the apneic situation. The brain sends down the messages. You better start clenching and grinding to wake yourself up and take a breath. Now, this guy, as I said, can go on 10, 15, 20, 30 times an hour and has a huge, huge effect on cardiovascular condition of our patients. So it's quite dramatic, but we have to consider this in are we adding to this scenario if it's undiagnosed? And this we already saw. So these are some of the studies that say if they have a hidden sleep problem and we make a normal occlusal splint, we may be greatly increasing the degree of their sleep problem indirectly by not knowing about it. And there are a couple of studies, this one's only 10 people, but it had a 40% increase in the severity of their sleep problem. So what do we do? What I like to do is before I make a routine night guard on someone that I'm not suspecting any type of a sleep problem, there are two little surveys that I have them fill out. This is called Stop Bang, and you can pull this down on the web very easily. And 8 questions. Have you been told that you snore? Are you tired during the day? Has anyone observed you stop breathing while you're sleeping? Usually your spouse. Are you being treated for high blood pressure? What's your BMI? And I like this particular one because you don't need an abacus. The chart for your BMI is right here. Age 50 years older. Is your neck circumference either 17 for male, 16 for female? Is your gender male? Well, being a male, here you get a strike here. If you're more than 50, you get another strike. And if you're on blood pressure medication, you already have 3 strikes. So this tells you here the rationale. If you get 2 or 3, is it moderate or severe sleep problem? So this at least gives you a clue. The other chart is called the Epworth Sleepiness Scale. And this is subjective. And on the scale of 0 to 3, are you likely to fall asleep as a passenger in a car? Anywhere from 0 to 3. And then you add all these up. And if you're in the teens, it gives you an indication that even subjectively, there's things that are happening. So if they score high on the Stop Bang, if they score high on the Epworth, before I would do a routine night guard, this is just me personally, I would recommend send them to their primary care to have a sleep study done. Okay. At least you will know that you're not adding to a problem which may at this time be undiagnosed, and you may be the hero in diagnosing a problem that has let go for years. I love their physicians, but they just do not spend the time with the patients that we do to get into all these things that we normally can get into very quickly in our practice. This is kind of a modification. I saw this. I've never made it where this little ramp here, the patient, he wasn't sure whether they had a sleep problem or not, and this kind of helped the mandible forward a little bit. I have never used it, but in case you see it, that's the goal behind it. How about if the patient already has a TMD problem and you're making a sleep appliance for them? Most of the studies are showing that a sleep appliance does not make a TMD problem worse. And in many cases, it actually stabilizes the jaw and helps our patients. So just a secondary thought off to the side. And these are all articles saying that TMD is not a contraindication to having routine dental sleep appliances. Now, many patients, when they go to a physician and they have a sleep study done and they score, they'll probably put them on the CPAP. CPAP machine is great, but only about 30% compliance. Our mandibular appliances now are doing very, very well, but at the same time, their compliance is way up over 80%. And so more and more and more physicians are understanding the thought process of using a sleep appliance. I put this in there because no matter what appliance you want, dogs seem to love these things. I don't know if it's the odor or anything else, but please keep it in your container or these little guys will come and they'll start munching on it. In fact, when I give this to the patient, they sign this piece of paper, how to keep it clean and everything else. And they also sign that I will keep it in the container and wait for my dog. And I joke, if they come in, you tell me your dog chewed it, I'll make you another one, but I'm going to charge you again because I told you specifically, keep it away from your dog. Okay. So this is the perfect dental storm. If we look at this whole thing, we're getting pretty close to end here. You can have sleep disturbances, sleep bruxism, GERD, daytime bruxism, saliva erosion, TMD, all wrapped together in one package. And sometimes it's difficult to decide what we're going to do for our patient. And I think where we're safe as general dentists, acute episodes go into like the quick splint or something else to help us diagnose what the problem is, extracapsular, do something for a short period of time to see if it improves. If it's not, it may be intracapsular, and I would strongly recommend then referral to a physician or a dentist who specializes in facial pain.
That's all, folks.
And if you want to contact me, there's my contact information. And I know this is a lot of information. I try to condense it as much as I can into about 50 minutes or so. Happy to take any questions if they're there. And if not, thank you for being with me. And thanks, Kattenbach, for setting up tonight's program. Lisa, anything I should try to answer?
Yeah, we do have a few in the queue. First one is a comment. I made the quick splint in the mandible. It shows less and is more comfy.
Not a problem.
Um, what should we recommend to parents for the children who have airborne, or I'm sorry, who have airway problems?
That have what problems?
What
Wait.
should we recommend to the parents for the children who have airway problems?
Oh. First thing I would do is probably send them to an orthodontist who's aware of airway problems. Many times in children, it's because we have a vaulted palate, and stage one of therapy is to open up the palate and expand the palate. Number two, what's going on with the tonsils? I know over the years there's been back and forth on taking the tonsils out or not, but they're called the primary source of a lot of airway problems. And usually they find with removal of the tonsils, that there's immediate improvement in the child unable to breathe again. So I think the first steps would be ENT, get rid of the tonsils. Number two, check the palate, make sure we don't have a vaulted palate. Go to stage one orthodontics, round out the palate, and many times that helps children dramatically. I don't have time to get into children, but this children are low-hanging fruit. If your child is not sleeping well, if your child is clenching and grinding your teeth, I can put the room full of 100 people, 100 children. Half of them have a sleep problem and half of them are ADHD. A psychologist interviewing these children would not be able to tell the difference. The same conditions. Bedwetting, not doing well in school, not being part of sports, being a loner, just not able to focus on anything. The same situation in obstructive sleep as you'd have with children with ADHD. And what bothers me is sometimes the decision is made quickly, and all these kids are on Adderall or Ritalin, and many times it is because no one has taken the time to evaluate their airway and their ability to sleep.
Are there any devices for denture wears other than CP?
That's a toughie because trying to put an appliance on the denture where you have to bring the mandible forward is a problem. And so probably the best that I've seen so far is to have the patient go to a CPAP machine. At least you're getting forced air coming through. Trying to put an appliance on the denture is going to keep the denture from staying or going back into its normal position without falling out. And so they're extremely difficult patients. I would probably, if you're in an area where you don't have a dentist who does appliances, you could contact the American Academy of Dental Sleep Medicine, and they will tell you who in your area sees patients for sleep problems. And there may be some in there that will deal with patients with dentures. Very difficult, though, extremely difficult.
What are your thoughts on abfraction?
Okay, you go back to what you think abfractions are caused by. When I was going to school, Grippo said, hey, abfractions are caused to when you go into lateral excursions, you have prematurities on your inclined planes. That causes a little bit of bending at the CEJ, and you get these little enamel spicks kicked out, and over a period of time, you get this very wedge-shaped abfraction. Some studies by Abraham said that, hey, I can duplicate this in the lab just with the toothpaste and the toothbrush. And he said that it's not so much the bristles on the toothbrush as it is the abrasiveness of the dentifrice that you're using. Whatever dentifrice you're using, you go online, and the abrasive ratio should be 250 or less. And the only ones that are really above that are those that I think do a lot of whitening that have a lot of abrasiveness in it. Now, how do you take care of it? I still think it's somewhere in between. A lot of the attractions I see, I can see some little cracks coming down, and I really see in the lateral excursions that they're contacting on teeth that should not be contacting, like bicuspids, for example. And in cases like that, I would then use that to put them in a guard, as long as they don't have a sleep problem, and take care of the infractions and tell them, I'll fill these up, but I want you in this night guard. And just filled them. I said, what if I do, more than likely they're going to kick out again. And I'm going to have to get you back in, and I'm going to have to charge you again to do the same thing. And so if you have the night guard, I feel, more inclined not to charge you because you're doing what I'm saying you're doing. So I'm somewhat in between. I think a little bit is weakness of some acid. Also, I think occlusal factor comes into play also.
What is the name of the sleep appliance you prescribe when patients do not want to use CPAP? And then also, can you name the dental lab
Yeah.
that you use?
There are 140 different appliances, and I can't name them all. Let me put it this way. They all do the same thing. They all bring the mandible forward. Some do it by rubber bands on the side where you change the length of the rubber band and the strength of the rubber band to either bring the mandible forward or have it come back. Now, here's the important thing if you get into sleep. You're titrating this appliance. You want it forward to open up the oropharyngeal airway space, yet you don't want to aggravate the joint. So sometimes you're aggravating the joint, so you have to move it back a little bit. So your appliances, no matter what they are, should have the ability to be titrated. Some have little devices on the side with your wrench, you can tighten them or loosen them, and it brings the mandible forward or back. One I like a lot is from Prosomnus, and they are in California here, Pleasanton, California. I like them because you get 3 upper and 3 lower appliances, and by interchanging those, you can bring the mandible forward or back. The reason why I like those is number one, they're very comfortable, but number two, the patient can't mess around with them by turning the screws or changing the rubber bands. So that to me is kind of the safest one that I like to use, but they all essentially do the same thing if adjusted properly.
Dr.
And the name of that
Santucci,
is Prosomnus, Prosomnus.